Good afternoon, and welcome to the American Brain Tumor Association's webinar series. My name is Umbreen Maan, Program Manager here at the ABTA. Today's webinar topic is How Metastatic Brain Tumors Affect Your Breast Cancer Care. Today's webinar will provide you with an overview of breast cancer brain metastases, a discussion on advancements in the treatment and management of brain metastases, and a peek into the workings of a brain tumor board. This webinar is presented in partnership with Living Beyond Breast Cancer, and it is my honor to welcome Janine Guglielmino to share a few words about Living Beyond Breast Cancer and introduce our speakers for today. Janine leads the mission delivery team at Living Beyond Breast Cancer, and for more than 20 years, she has supported the development of high-quality education across the organization's programs, content, and outreach. Janine works closely with the metastatic breast cancer community and represents Living Beyond Breast Cancer on the ABTA's Metastatic Brain Tumor Initiative. Thank you so much for joining us, Janine.
Thanks very much for having me, Umbreen. And welcome, everyone. As Umbreen said, my name is Janine Guglielmino, and I'm here today representing Living Beyond Breast Cancer. For those of you who are not familiar with LBBC, I just wanted to share a little bit about who we are and what we do. We're a more than 30-year-old national nonprofit organization with the vision that no one impacted by breast cancer should feel uninformed or alone. And our mission is to connect people with trusted breast cancer information and a community of support. And part of delivering on our mission and vision is partnerships like the one that we have with the American Brain Tumor Association, where we're serving on the Metastatic Brain Tumor Initiative. We're really proud to be able to work with our partners who work in other tumor types and to learn more about the ways that people with metastatic brain tumors have things in common and things that we can do together to make a difference for everyone with metastatic disease. A little bit about what we offer. Living Beyond Breast Cancer offers a wide variety of both live programs and on-demand content, focusing on all stages of breast cancer, but with a special focus on metastatic breast cancer. In just a few weeks, we're actually holding one of our largest programs, which is our 2022 Conference on Metastatic Breast Cancer, the weekend of April 23rd and 24th, which will include a workshop focusing on brain metastases. And I hope some of you will join us. You can go to lbbc.org to learn more about that program and about all the programs that we offer. So now, without further delay, I'd like to introduce our amazing panelists today. Each one represents a different member of the care team that helps support and manage brain metastases and breast cancer. And I'm looking forward to a really vibrant discussion with this group. Dr. Nancy Lin is Associate Chief in the Division of Breast Oncology and Director of the Metastatic Breast Cancer Program at Dana-Farber Cancer Institute. Dr. Lin has led multiple trials of novel systemic approaches for metastatic breast cancer that include people with breast cancer brain metastases. Dr. Lin will be our facilitator today for the panel. Next, I'd like to introduce Dr. Keshan Chaitanyana, a board-certified fellowship-trained neurosurgeon at the Mayo Clinic. He specializes in the treatment of people with primary brain tumors, such as gliomas, meningiomas, and pituitary tumors, as well as skull base and metastatic brain tumors. He practices the most advanced treatments in minimally invasive surgery, endoscopic surgery, and awake brain mapping. Dr. Jennifer Yu is an associate professor and staff physician in the Department of Radiation Oncology, Department of Cancer Biology, Center for Cancer Stem Cell Biology at the Cleveland Clinic, and is a program leader of the Developmental Therapeutics Program and co-leader of the Cancer Stem Cell Working Group at the NCI Designated Case Comprehensive Cancer Center. And finally, I'd also like to welcome Dr. Manmeet Ahluwalia, who is the Chief of Solid Tumor Medical Oncology, Deputy Director and Chief Scientific Officer at Miami Cancer Institute. As a neuro-oncologist, Dr. Ahluwalia Primary areas of research and patient care are primary tumors and brain metastases. So I'd like to welcome all of you to the screen and thank you for joining us. And I'll turn it over to you, Dr. Lin, to begin the conversation.
Thank you so much, Janine. Well, we hope that this brief overview session today provides you with a better understanding of brain metastases and breast cancer. We also want to stress how important your opinions, priorities, and preferences are to your care, as we believe the best care is that which involves you, the patient, in the decision-making process. We will now take a dive into each of our panelists' area of expertise to learn about important treatment options, advancements, and considerations when managing brain metastases. Dr. Chaitanya, can you start us off by telling us more about the surgical approaches you would consider for patients who have brain metastases and breast cancer?
Yes, definitely. Thanks for having me here. If you can go to the next slides. So basically, there's a variety of different approaches that we can do for brain tumors, from the conventional to the more minimally invasive approaches. We typically only offer surgery for patients who would benefit from the surgery. So patients that are symptomatic from a brain lesion, or that they're having a need for diagnosis or increased swelling. If there's no need for diagnosis or tissue, then we typically don't offer surgery unless it would benefit the patient. The typical overview of how we do the brain tumor is that typically before the brain surgery, you would get imaging that would serve as our GPS system during the surgery. We would make an incision over the lesion. We would do what's called a craniotomy, where we remove the bone overlying the lesion, open the dura, which is the covering over the brain, and then resect just the brain tumor, trying to preserve the surrounding areas. And as you can see, these images are typical brain mapping surgery, or when the tumor is in eloquent regions, those areas that control speech or motor function or even cognitive function, we can map those areas. All these number tickets that you can see in the top left are areas that correspond to functional areas that we have to preserve, and we're able to map around that area and resect the tumor without that, with preserving those areas without involving those eloquent regions. After we remove the tumor, we close the dura, which is the lining of the brain again, with sutures. We replace the bone, and we use titanium plates to fix the bone to the native bone to allow it to heal in place. And we close the scalp with sutures and typically staples on the skin. However, nowadays, we don't really have to do a conventional approach for a lot of tumors. If you can go to the next slide. So we have minimally invasive ways. So we have tubular retractors for deep-seated brain lesions. These tubes kind of look like big pens. These big pen tubes, basically we advance the tube through the brain to protect the surrounding areas. And you can see we're working through a protected corridor that's less than the diameter of a dime. What that does is it preserves a lot of the surrounding brain structures and it doesn't require us to open the brain so widely, as you can see in the previous images. There's also laser interstitial thermal therapy that we can use also for these tumors, where we stick an electrode that you can see in the bottom images, the bottom right image, and this laser catheter goes into the tumor. Then we heat it with laser, and that allows it to kill the tumor cells by being even more minimally invasive. Here you can see just a stab incision in skin with a very pinpoint incision, spares the surrounding areas and allows the brain to heal faster. We also have keyhole craniotomies, where if we need to remove the tumor because there's a lot of swelling, a keyhole is similar to a keyhole that you use to open the door. We have a very small opening in the bone that you can see in the bottom image on the left. The opening is like the size of a nickel, and then we work through that area to remove the tumor. So we have a lot of different ways to address the lesion, but each way is catered towards the patient and their situation. But we have a lot of options if surgery is needed.
Great, thanks so much. It's amazing how much surgery has advanced over the last years. With this understanding of surgery, let's now take a step back and provide an overview of breast cancer brain metastases from a big picture standpoint, and then we'll dive back in with the other modalities of treatment. If we think about breast cancer, even when it's metastasized to the brain, we still think about it in these various breast cancer subtypes. And the three major subtypes that we think about are estrogen receptor positive breast cancer, which we define as those cancers that are estrogen receptor positive and also HER2 negative. HER2 positive breast cancers, which can be either estrogen positive or negative and are HER2 positive by our traditional criteria, and triple negative breast cancers, which are negative for all three of the usual markers, estrogen, progesterone, and HER2. Now, within these subtypes, there are still yet other subdivisions. For example, lobular breast cancers are typically estrogen receptor positive, although not always. And there is a new category that you may be starting to hear more about called HER2 low, which are cancers that are HER2 negative by our traditional criteria, but still have a small amount of HER2 staining. If you're not sure what type of breast cancer you have, talk to your doctor. This is a very important piece of information to have if you're thinking about looking online, for example, for different treatment options, because so much of what we do is subtype specific in breast cancer. Next slide. Who is at risk for brain metastases? The good news is that for patients who have early stage disease, the brain is a very uncommon location for first breast cancer recurrence. However, once patients develop metastatic breast cancer, the risk of brain metastases over time does increase. So it's been estimated at 10 to 15% in patients with estrogen receptor positive breast cancer, 40 to 50% in patients with HER2 positive breast cancer, and between 25 to 45% in patients with triple negative breast cancer. There are other risk factors that have been identified, including patients who have germline BRCA1 or BRCA2 mutations, young age, the presence of cancer in the lungs, and also lobular histology or lobular breast cancers are a little bit more likely to develop what's called leptomeningeal disease. One key takeaway is that if you have neurological symptoms, and we'll talk about what those might be, it's very important, especially if you're in a high-risk group, to tell your doctor about those symptoms so that you can be evaluated. Next slide. So what are the common symptoms of brain metastases? The most common symptom is headaches. And the kind of red flags that we ask for are headaches, especially if they're associated with nausea or vomiting, or if they're associated with other neurological symptoms like problems with balance or falls or coordination, weakness, especially if it's on one side of the body compared to the other, numbness, again, especially if it's not symmetrical and it's not the usual chemotherapy neuropathy that we might otherwise expect, and less commonly seizures. Next slide. How are brain metastases evaluated? The most typical type of test would be an MRI of the brain with a special kind of IV contrast dye, and this gives much better pictures than a CAT scan. Often oncologists, if you are found to have cancer in the brain, will also recommend scans of your body to see what the status of the cancer is outside of your brain. Next slide. And then what is leptomeningeal disease, otherwise known as LMD? And this is a very particular type of presentation of breast cancer that ends up in the spinal fluid and along the lining of the brain and the spinal cord. The symptoms for leptomeningeal disease can be similar to those with regular brain metastases, including headaches, nausea, and vomiting, but also we can see neck or back pain, problems with eye movements, facial droop, difficulty swallowing, shooting or nerve pains, weakness, bowel or bladder issues, or seizures. So again, if you have these symptoms and they're not obviously attributable to, for example, chemotherapy side effects, it's very important to tell your doctor about them. Next slide. And how is leptomeningeal disease evaluated? Typically with an MRI, but this time of the brain and full spine, and sometimes a spinal tap. And similarly to patients who have brain metastases, typically there will also be imaging of the rest of your body to look for the status of the cancer there as well. Next slide. And so who might be involved in a multidisciplinary team? And in the situation here, you'll typically be cared for by a medical oncologist. Very often a radiation oncologist will be involved in your care. Sometimes a neurosurgeon might be called in either for surgery to remove tumors, or in the case of leptomeningeal disease, there are some maneuvers to try to reduce or improve symptoms. A neuro-oncologist, a neuroradiologist who will help read the imaging, and a pathologist in the case of surgery. Next slide. And so we're going to go back and dive right back in, and we'll welcome Dr. Yu, who will share more insight on the radiation therapy options for patients with brain metastases.
Hi, good afternoon, everyone. So radiation can come in two different flavors. One is called stereotactic radiosurgery, and the other is whole brain radiation treatment. And depending on the number of brain metastases, the size of these, the pattern of the brain metastases, whether there might be leptomeningeal disease, these are all factors that we take into consideration when thinking about whether a patient might benefit more from stereotactic radiosurgery or whole brain radiation. And then we also look at other factors like how well the patient's doing, their performance status, as well as the burden of disease outside of the brain. And so here are some images from a patient who has a single brain metastasis, who's being treated with stereotactic radiosurgery. And you can see the small metastasis. This is outlined in red, and then the radiation dose is designed to treat just that metastasis. So with stereotactic radiosurgery, this is a one-day procedure, and it's very focused type of radiation on just the metastases that we see on the MRI scan. Now, there may be some micro metastatic sites that are just too small for us to resolve on the MRI scan. And so this form of radiation, the stereotactic radiosurgery, is not able to treat what we cannot see. So stereotactic radiosurgery is associated with high rates of local control. And because we only focus the radiation on the metastasis that we see, there are fewer side effects because there's less radiation involving normal parts of the brain. Next slide. So whole brain radiation is another type of radiation therapy that treats the entire brain, just like it says. So it treats the brain metastases that we can see, as well as any small microscopic metastases within the brain that are beyond or below the limit of resolution of the MRI scan. And so whole brain radiation is typically used for patients that may have multiple brain metastases. And because it treats both the brain metastases as well as a large volume of normal brain, it is associated with changes in neurocognitive function, so patients can see a decline in neurocognitive function over time. And so there are different ways that we can try to minimize those late toxicities of whole brain radiation. So one is called hippocampal avoidance. So if you look at the panel in the upper left-hand corner, here's a patient who has whole brain radiation treatment, and the red is the high dose of radiation. And you can see it encompasses the entire brain. But with hippocampal avoidance radiation, whole brain radiation treatment, the areas around the hippocampus are spared high doses of radiation. And since these centers are important in memory and in cognition, our clinical trials have shown that patients that receive hippocampal avoidance radiation therapy, they have less cognitive decline. And by patient-reported symptom burden, you can see that patients that have this hippocampal avoidance whole brain radiation, they show better cognition, less fatigue. They report less trouble speaking and improved memory as well. And so there's hippocampal avoidance, whole brain radiation that can improve neurocognitive function compared to those patients who only receive whole brain radiation. And then there's also pharmacologic means of trying to preserve the neurocognitive function, and that's with a drug called memantine. So with the addition of memantine to whole brain radiation treatment, then neurocognition can also be spared a bit better.
Thank you, Dr. Yu. We'll now have Dr. Ahluwalia share important management considerations from a neuro-oncology perspective.
Thank you so much, Nancy. Next slide, please. So from a neuro-oncology perspective, Dr. Lin highlighted there's a couple of major issues that can come, not in everyone, but in select patients, include seizures And seizure management can be a key component from a neuro-oncology perspective. The patients who are at highest risk for seizures with brain metastases included melanoma and lung cancer. In breast cancer, brain metastases, this is a relatively less of an issue, but can occur. We do not do prophylaxis with anti-seizure drugs. That means if someone gets brain metastases, we do not automatically put them on medications for seizures, because these medications can, in turn, have side effects that include, things like tiredness and others. If your brain metastases is such that it is causing a foci that is leading to seizures, then the surgeons like Dr. Chaijana can come in, and if they can remove the brain metastases, that is sometimes recommended to help with the seizure control. And Dr. You had talked about radiation and radiosurgery. Sometimes that can lead to seizures, especially because when you give radiation, sometimes it can lead to swelling around it. So sometimes some people who do these procedures may use steroids or anti-seizure medications to minimize the risk. But this is given generally for a short period of time, mostly days. Next slide, please. Another thing that can happen when someone has brain metastases, as you can see here in the MRI, there can be swelling, because anything that irritates the brain can lead to edema or swelling. And hence, traditionally, we have used steroids. And again, the physician typically tries to use the least amount of steroids and for the least amount of time, because in long runs, steroids themselves can lead to side effects, and sometimes can even impact outcome of drugs, especially as we are looking into more and more immunotherapy as a potential modality to treat our patients. And that's where sometimes drugs like bevacizumab, which can also lead to decrease in swelling, can be used. And sometimes when radiation-related changes can become a challenge in the brain with someone with brain metastases, bevacizumab is used again for anywhere from 2 to 4 doses for a brief period of time to alleviate the need for prolonged usage with steroids. Thank you.
Thank you, Dr. Ahluwalia. To conclude our discussion on treatment advances and management, I'd like to take some time to talk about systemic therapies and how they pertain to breast cancer brain metastases. Next slide. So as I said earlier, we really think about the treatment options systemically based on tumor subtype. And so I'm going to go through by tumor subtype. And first, we'll go through the treatment options systemically for patients who have HER2-positive breast cancer brain metastases. Fortunately for this subtype of breast cancer, there have been significant advances. And so there are a number of regimens that do work in the brain. One of the things that we'll talk about in the tumor board that's to come is when we think about systemic treatment for cancer in the brain versus a local treatment like surgery or radiation. But if one wants to use systemic treatment, here are some of the possibilities. One is for the combination of tucatinib, which is an oral pill, with capecitabine and oral chemotherapy, along with IV Herceptin. There are also data to support additional regimens, including an older regimen of lapatinib and capecitabine, which we don't give very much anymore. There is also a regimen with a combination of neratinib and capecitabine. And then some of the IV drugs, which we historically have thought are too big to work in the brain. In fact, there is emerging data that they can be effective in the brain. And these include the antibody drug conjugate drugs called TDM1 or Kadcyla, and a drug called trastuzumab deruxtecan or Enhertu. And then there's some options that are supported by small clinical trials or reports of patients who've had individual benefit from treatment, and that would be trastuzumab or Herceptin combined with various types of more regular chemotherapy. And finally, there are a number of clinical trials. Next slide. For HER2-positive breast cancer, there are quite a number of clinical trials that include patients with brain metastases, including patients who have so-called active brain metastases, meaning the brain metastases are worsening at the time of the clinical trial enrollment. These include combinations of TDM1 with either tucatinib or neratinib, combinations of trastuzumab deruxtecan or Enhertu with tucatinib or on its own, newer HER2-targeted oral medicines like ZN-1041 and DZD-1516, and then more novel approaches, including medications that target other pathways or even immunotherapy CAR T-cell type approaches. Next slide. For patients who have HER2-negative breast cancer brain metastases, these include patients who have triple-negative breast cancer or estrogen-positive HER2-negative breast cancer. The data are more thin because there have been fewer clinical trials conducted in this group of patients. But we use a number of traditional chemotherapy drugs like capecitabine, anthracyclines, platinum salts. And also for those patients who have estrogen-positive breast cancers, sometimes the hormonal therapies can be effective. And these include medicines like tamoxifen or aromatase inhibitors, or some of the CDK4/6 inhibitors, for example, abemaciclib or Verzenio. Next slide. And in terms of clinical trials, again, there are a number of clinical trials that include patients with active brain metastases. Most clinical trials do include patients with stable brain metastases. I'll highlight a few of them here. There is a national trial that is being conducted for a medicine called sacituzumab or Trodelvy, which is currently FDA approved for triple-negative breast cancer patients. But this trial includes patients also who have estrogen receptor positive breast cancer. And for those patients who have brain metastases, they can enroll into this clinical trial. Again, it's a trial that is enrolling nationally. Another nationally enrolling trial is a study where patients who've had surgery for their brain metastasis can have genomic testing of the tumor. And if the tumor has one of several specific alterations that match to a treatment on the trial, patients can enter the trial and receive the trial treatment that's matched to their tumor. There are a number of hormonal therapies that are currently being studied for patients who have estrogen-positive, HER2-negative brain metastases, and then some more novel treatments, including a medicine called niraparib, which is a PARP inhibitor, and then an immunotherapy combination for patients who have leptomeningeal disease. Next slide. So what I'd like to do next is introduce our virtual tumor board, really to explore how members of your multidisciplinary care team work together to make treatment recommendations. So I'm now going to invite each of our panelists to come on camera and unmute themselves to take part in the simulation of a brain tumor board. We hope this virtual tumor board helps you to provide some insight into the collaborative decision-making process that your care team engages in. So we're going to discuss one case. This is a 38-year-old woman who presented with stage 3 estrogen-positive, HER2-positive breast cancer in 2018. She was treated with chemotherapy, trastuzumab, and pertuzumab for 12 weeks, and then she had surgery where she had residual disease in her lymph nodes, and she received 4 rounds of AC chemotherapy followed by TDM1 or Kadcyla, which she finished in June of 2019. Afterwards, she received ovarian suppression and an aromatase inhibitor hormonal medication. In December of 2020, she presented with headaches. This was associated with nausea and vomiting, and she had a very good performance status. She was otherwise very healthy. And because of the headaches with nausea, her doctor ordered an MRI. Next slide. This is what the MRI showed. It showed a single left frontal brain metastasis. She also had a CAT scan of her body at that time showing 3 areas in her liver that were suspicious for cancer. She had normal lab tests, and again, she was very healthy with the exception of these recent scan results. Next slide. So I'm going to turn to Dr. Chaitanya and ask about the role of surgery in this situation and the kinds of things that go through your mind as you're considering whether surgery would be a good option for a patient.
Yeah, so for this patient, she's young, she has a known history of breast cancer, so it's assumed that this brain lesion is a breast cancer metastasis. She also has other lesions in her body. So I think for surgery wise, I think we know the diagnosis, or we assume the diagnosis because of her cancer history and the lesion. But we would offer typically surgery for this patient just because she's symptomatic from her brain tumor. So she has that left frontal brain tumor, and the white area around it on the imaging on the right shows a lot of swelling. So in order to decrease the pressure in her brain or the mass effect, we would offer surgery to remove the tumor to decrease that swelling. At the same time of removing the tumor, we would also confirm the diagnosis of breast cancer metastasis if that's the case. So a patient that's healthy, that's young, that has a solitary lesion that's symptomatic that we can pinpoint, we would typically offer surgery. The type of surgery we would do is a conventional typical craniotomy for this case. Since it's right on the surface, we would open up the skin overlying that area, open up the bone, and then remove the tumor. The surgery itself is not a very long surgery for this tumor because it's not in an eloquent location near speech areas. It's right on the surface. So typically it would take an hour of our time, maybe 2 hours of total. After the surgery, she would typically go to the step-down unit, not the ICU. And most people do go home the next day or the day after, but most go home the next day. The risks involved, though, are very small, but they're present. Everything that we do, it has 4 categories of risk. It's always bleeding, pain, infection, and damage to nearby structures. So in terms of bleeding, we're not near any major arteries or veins. So the risk in this case is very small of bleeding. Pain should be minimal. She has headaches already, but surgery would contribute to some headaches, but it's usually well controlled. Infection is a very rare phenomenon, and we cover with antibiotics. And like I said, there's damage to nearby structures. We're not near anything eloquent, so it'd be a very practical or very safe surgery for this case.
Great, thanks so much. Dr. Ahluwalia, what would be the role of steroids, and is there a role for anticonvulsants or seizure medications in this case?
Yeah, so clearly here the patient's symptomatic. The patient has headache and she's having some nausea. So clearly the thing to do is institute steroids. Typically, we do that based on how much swelling there is and how symptomatic the patient is. Most common steroid we use is dexamethasone, and one could use doses up to 4 milligrams, whether once a day, twice a day. For patients who are very symptomatic and need to be admitted, sometimes we go higher doses. But as Dr. Chaichana had alluded to, once the surgery is performed, that leads to taking out of the brain metastases, and a lot of times that will help with the swelling. And so we can slowly but surely decrease the steroids. As we had initially covered as well, there is no reason to give anticonvulsants or medications that tackle steroids as seizures prophylactically. So if the patient has not had that, we would not institute anticonvulsants. And obviously, as we saw before, in breast cancer, it's a little bit less compared to melanoma and lung cancer. So I would just observe such a patient and work with the surgeons and the radiation oncologist in steroid management as the patient recovers.
Great. Dr. Yu, could you speak to the role of radiation and what type of radiation you would recommend and the timing of this?
Sure. So despite having the entire metastasis removed, the patient still has a considerable risk of having the brain metastasis come back locally or come back within that tumor bed. So to decrease that risk of recurrence, I would recommend radiation treatment. And as I had discussed before, there are 2 different flavors. One is stereotactic radiosurgery, which can be performed just to the tumor bed, and the other is whole brain radiation treatment. Now, in the absence of the patient having other brain metastases or a pattern of leptomeningeal spread, then I favor doing stereotactic radiosurgery, which again can offer high rates of local control. And because it's only focused on the resection cavity, then we can reduce the risk of long-term neurocognitive deficits. Now, before we start with the radiation treatment, we would want to make sure that the patient has recovered from their surgery and that their wound has healed.
Great. So I'm going to speak a little bit about something called subtype switching, which is that when we have the tumor removed, obviously we do want to make sure that this confirm with pathology that this is in fact breast cancer. And then the other thing is that we always order estrogen, progesterone, HER2 testing to be repeated on the tumor. And that's because there have been several studies to show that there can be some change between the original breast cancer and the brain metastasis. In most cases where cancer starts out as HER2 positive, it stays HER2 positive. It's pretty rare to lose the HER2. But in patients who start out HER2 negative, about 15% of the time, the brain metastasis is actually HER2 positive. And that would have major implications on how we can treat the cancer afterwards. And so it's very important to make sure that that receptor testing is repeated on the brain metastasis. And in addition, the estrogen receptor staining can frequently go away. Somewhere around a third of the time, we lose the estrogen receptor staining. And again, that would influence the potential treatment options afterwards. You wouldn't want to give hormonal therapy in a patient who's lost estrogen receptor staining. And then from a systemic therapy standpoint, I think the first question that I always think of is, do we need at this point to choose something that works in the brain or not? And in this case, where surgery has removed the tumor and she's going to receive radiation treatment to the area of the surgical cavity, at least for the time being, we can consider that the cancer in the brain is being adequately treated. And so we don't have to necessarily pick a systemic treatment that works in the brain. We might choose to at certain points in time, but we don't have to at this point. And because she has cancer in her liver, I would typically choose the so-called usual first-line treatment. And in the algorithm for treating HER2-positive breast cancer, we usually start with Taxol, Herceptin, and Perjeta. And so that's what I would recommend for her. Next slide. So in fact, this patient underwent surgical resection. She was able to go home, we'll say the next day after surgery. Testing of the tumor showed that, in fact, her tumor did lose estrogen receptor staining. Remember, her cancer was originally estrogen receptor positive, but it remained HER2 positive. She received radiation treatment to the resection cavity, and she started chemotherapy for treatment of her liver metastases. Next slide. Now, at this point in time, we continue to follow patients with routine brain MRIs and CAT scans, usually every few months. And a lot of different things can happen. So we're going to just play out a couple of different situations to get a flavor of how different types of situations might lead to different treatment recommendations. So let's imagine she does very well. She has shrinkage of her liver metastases with this treatment. And a year and a half later, she develops 3 new areas of cancer in her brain. They're all very small. She has no symptoms because we've been doing regular scans to look for this. And her liver metastases and cancer outside of her body remains under very good control. So I'm going to turn to Dr. Yu and ask for your thoughts about what sort of treatments you might think about for her in this situation.
Yeah, so for this particular patient, there's been quite a long interval since she had her initial surgery and radiation, no other evidence of disease in the body. So she just has these small, 3 small brain metastases. I would recommend stereotactic radiosurgery for her, prevent the growth of these brain metastases. So that would be my favorite approach.
Great. What would you tell her in terms of any anticipated side effects from it? How would you counsel her from that standpoint?
Yeah, so this type of treatment is generally very well tolerated. It's a 1-day procedure. Patients usually can go on with their normal activities the day after the procedure. So again, very well tolerated. There can be some swelling that occurs right around the brain metastases that we're treating. So we would give her a course of steroids, a short course of steroids to reduce any risk of swelling. But should she become symptomatic, develop headaches, nausea, vomiting, seizures, then we would adjust those medications. There's a small risk of, so radiosurgery can be performed with different types of machines. There's a gamma knife radiosurgery machine, usually using a head frame which affixes to the actual skull. And so there is a small risk of bleeding, infection where those pin sites are. There's also CyberKnife radiosurgery. There's linear accelerator-based radiosurgery as well, where a mask is made. And so the risk of bleeding and infection is not there for those types of radiosurgery delivery techniques. Usually for patients that receive radiosurgery, they maintain their hair. Sometimes if the lesion is very close to the surface, then hair loss can be present as well.
Great, thank you. And from a systemic therapy standpoint, in this situation where there's been a long interval and her cancer outside of her brain remains well controlled, I agree, I would refer this patient to radiation, and then I would just leave her chemotherapy alone. Probably at this point, she would be transitioned just to Herceptin Perjeta without the Taxol chemotherapy, and I would just let her be at that point in time. I will note that obviously in this situation, people are often very worried about another event happening in their brain. And my colleague, Dr. Carrie Anders and Dr. Sarah Sammons, both at Duke, are planning to launch a clinical trial in this situation where patients who have radiation would be randomly assigned to continue Herceptin Perjeta, which would be the standard of care, or to be assigned to receive Herceptin Perjeta and tucatinib in an attempt to see whether or not adding the tucatinib might actually delay or prevent the development of new brain metastases. And I believe Dr. Ahluwalia has a trial also that is going to be launching, also looking at different types of sort of combined systemic and radiation techniques. I wanted to just invite you to tell us about that trial.
Yeah, no, so thank you, Nancy, and I agree with the plan discussed by Dr. Yu and yourself. In this case, well, one of the things that we are trying to do in our research aspects is how to look at combinatorial approaches using radiosurgery. And as you are aware, tucatinib, along with capecitabine and Herceptin, trastuzumab, has been shown to have a lot of good effect. So we have a study which is looking at the combinatorial approaches, because as you know, a lot of these therapies are now being combined with radiosurgery, which has kind of become foundation or treatment aspect for most patients. So we have a study coming up which would look at radiosurgery combined with tucatinib for a couple of weeks, which will then be followed by tucatinib, trastuzumab, and capecitabine. But in this case, I would probably agree totally with your perspective, because the patient is doing well systemically. A lot of times patients progress both systemically and in the brain, and that's where typically we say, okay, let's even change the systemic treatment.
Right, exactly. So we're going to switch around the case a little bit and imagine that instead of 18 months before something new happens, let's suppose that 6 months after her original surgery, she develops 5 new brain metastases, all quite small, less than a centimeter, and she also has worsening of the cancer in her liver to a small degree. And so I'm just going to go back to Dr. Yu and ask you to just outline some of the radiation options, and then I'll outline some of the systemic options, and we can discuss back and forth with the group as to which one we might choose for her, or we might offer to her. Obviously, she would be the one making the ultimate decision.
Yeah, so assuming these are new brain metastases, these have not been treated before. She has 5 small ones, now with a little, some more disease progression in the liver. Assuming her performance status is still excellent, then I would still offer stereotactic radiosurgery for her. The number, the size, both of those matter when considering stereotactic radiosurgery versus a whole brain radiation approach. Yeah.
Great. Yeah, no, I mean, I totally agree that I would, in these patients, we try to avoid whole brain or delay it as long as we reasonably can. Sometimes the situation just really calls for whole brain radiation. And I think the emerging question that has come up, which is still unanswered from the standpoint of clinical trials, but is what we end up talking a lot about to patients and with each other, is, in which cases we might actually defer radiation completely and just try a systemic approach with very close follow-up. And so she is somebody who would have qualified, for example, for the HER2CLIMB clinical trial, which was the trial that tested tucatinib, Xeloda, and Herceptin. And in that trial, about half of patients had tumor shrinkage in their brain with the combination, and very few patients, less than 5%, had cancer worsening in the brain on their first post-treatment scan. So although the chance of significant tumor shrinkage was about 50-50, very few people had worsening immediately after starting. So I think that is reassuring. And so what we end up doing in these situations is, what I do is I talk with my radiation oncology colleague. Are there lesions that are of particular concern? If they got a little bit bigger, it would be more difficult to radiate them. They're in a location that's concerning from a symptom standpoint, et cetera, et cetera. And if the answer is no, the lesions are all, in relatively quiet locations in the brain, and the patient has no symptoms or relatively few symptoms, we might consider giving systemic therapy with a scan within 6 to 9 weeks to make sure that the patient is actually responding, and actually try to avoid the radiation. So I think this is kind of an evolving area, but it really speaks to the importance of, I don't make these decisions on my own. I work with my radiation oncology colleagues because I don't want to offer something that's not safe. And we sort of talk together about what would make sense. And patients also have very different feelings too. Some people like the certainty of the radiation option, which is essentially almost guaranteed, not exactly, but pretty close to it, to lead to a tumor response. And some would prefer to avoid the radiation if they can. I'm curious, Dr. Yu, about the approach that you take, if it's similar or different. This is something that's really evolving across the country and around the world. So I think there's not like a set standard yet at this point in time.
Right. I absolutely agree with you that if with the right patient who can follow up, and it's really important to get that MRI scan about a month or two after initiating systemic treatment, such that if the tumor were to grow larger, that we could then initiate radiation as soon as possible. So I agree with you that the dialogue is important. If the lesions are punctate lesions, so they're very, very small, 2-3 millimeters in size, asymptomatic, then I think it's very reasonable to pursue systemic treatment, especially when a patient has disease outside of the body. That's where there's progression. So,
great.
Yeah, I think that's very reasonable.
And then the last topic I want to go through before we go to the Q&A is really what would you think about if the patient were later to develop something called radiation necrosis? So maybe I can turn to Dr. Ahluwalia and ask him to tell us what that is, and then we can think about how we approach patients with symptomatic radiation necrosis.
Yeah, sure. So again, I think it's a multidisciplinary effort. We typically review such films in the tumor board, talk with our radiation oncology colleagues, depends on how symptomatic patient is. And if they're symptomatic, because a lot of times we will see radiation changes on the MRI because we image our patients so much. Sometimes patients not symptomatic. And those aspects, and if the patient is reliable and is compliant, we just follow the imaging. If the patient does get symptomatic, most of the times our first go-to treatment is steroids. And again, the effort is to use the least amount of steroids. And then If patient needs to go on steroids, we again follow them if they have symptoms. And if the symptoms start getting better, we start to taper them and decrease the steroids, and then see what's the response on the imaging. If someone develops a steroid dependency or the radiation necrosis, is requiring large amount of steroids, in select cases, we then tend to use medications like bevacizumab. There have been small but randomized trials showing that in steroid refractory radiation necrosis, bevacizumab can be helpful. Most of the times we give intravenous treatment every 2 weeks. Sometimes we use half the dose we use in brain tumors. And typically patients will need around 2 to 4 treatments and then can wean off their steroids completely. And then there are other aspects which less commonly used: hyperbaric oxygen, pentoxifylline, vitamin E, which can offer help. But I think the first 2 choices are that. And then obviously we also didn't get involved the surgeons around. People like Dr. Chachana can look into efforts, where we can get help from the surgeons.
Yeah, so last question will be to Dr. Chachana, which is, in which kind of situations of radiation necrosis would you consider surgical resection?
So for radiation necrosis, I would consider surgical resection or surgical intervention for anything that's not responsive to various therapies. If they need prolonged steroids and they're not responsive to that, we have a lot of options for that, and I really rely on the tumor board to guide us. But we can resect it through conventional surgery, or we can actually do laser interstitial thermal therapy to ablate it or burn it. So both of those options are available to those, but I really rely on a tumor board situation where they run out of options from a medical perspective to address the radiation necrosis.
Great. Can you tell us a little bit more what is LIT, or laser thermal ablation?
Yeah, LIT is also called, is the abbreviation for, it's LITT, that's the abbreviation for laser interstitial thermal therapy. And so what that means is we put a catheter and an electrode into the tumor itself under stereotactic guidance or GPS guidance. That electrode has the ability to burn it with laser. The laser spreads primarily limited to the tumor tissue because it has a different density than the surrounding structures. By burning the tumor tissue, what it does is decreases the vascularity in that area, and that translates into decreased edema or decreased swelling. Post-surgically, there can be more swelling just because of the intervention, but typically over time that swelling goes away in cases of radiation necrosis. So it's a minimally invasive option for deep-seated lesions that aren't safe for conventional surgical resection.
Right. Thank you. Well, we hope this virtual tumor board was able to provide you a sense of how your team works together in your care. We will now open the floor for questions.
Thank you so much for that wonderful discussion. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here, we discussed systemic therapies. Is Temodar ever utilized for brain metastases? Is it effective in breast cancer?
And Temodar, or temozolomide, is an oral chemotherapy medication. It's very commonly used for patients with glioblastoma, that's a primary brain tumor. For patients with breast cancer, Temodar is less commonly used because on its own, it's not a very effective breast cancer drug.
Thank you so much. And during the discussion, we also talked about, I believe, a trial maybe with Herceptin and Perjeta. We have a question from one of our attendees who's wondering, how are you able to overcome the blood-brain barrier when using treatments like Herceptin and Perjeta?
Yeah, good question. I saw there was also a question about whether Herceptin Perjeta increases the brain met risk, which it does not. In fact, in the clinical trial called Cleopatra, where patients either received chemo plus Herceptin or chemo plus Herceptin and Perjeta, adding the Perjeta actually prolonged the time to the first brain metastasis diagnosis. However, Herceptin Perjeta, as given in the standard dose, does not, we don't think, get into the brain very well. We did do a phase 2 clinical trial that looked at so-called high-dose Herceptin, so giving 3 times the normal dose. We don't do that routinely, but in some situations we might consider it. And that was shown in the trial to have some benefit in patients who have worsening cancer in the brain. Again, because we have other options, we usually use those first, but we do sometimes use that in patients who've gone through the usual options.
Thank you so much. Also, throughout the presentation, we talked about some potential cognitive decline that can come from certain treatments. Are these cognitive effects or symptoms that patients experience temporary? Are they long-term? Can anything be done to help resolve the issues once a patient starts experiencing them?
Dr. Alawali, I'll have you.
Yes, sure. So again, so neurocognition or neurocognitive decline is a challenging aspect that our patients face, especially as we have patients who live long-term now with brain metastases. And it can be multifactorial. Sometimes it is associated with radiation, typically with the whole brain radiation. And as Dr. Yu had alluded to, we tend to now use hippocampal whole brain radiation in those patients, which minimizes the risk for neurocognitive decline. Studies have shown that. Then also we use drugs like memantine, which can also help decrease the rate of decline. And now we have trials which are looking at combination of hippocampal sparing radiation with memantine to decrease that. Now, also important thing to remember is one of the major things that leads to neurocognitive decline is the tumor itself. So more effective management of tumor, whether using new targeted therapies that Dr. Lin alluded to, and we are very excited about a lot of drugs now we have to help our patients, which was not the case a decade back. So if we can make a more effective control of the brain metastases, either using radiosurgery, which leads to less decline in neurocognition compared to whole brain radiation, and then effectively control their tumor, that helps us prevent this. Now, a lot of times, unfortunately, if neurocognition decline sets in, it's typically difficult to reverse it. But we always advise people, don't use it, you lose it. So make sure you are mentally stimulated, keep yourself busy. Things like meditation and being active helps.
Thank you so much for sharing that wonderful advice. Dr. Lin, I think you might have used this term in your section of the presentation, referring to stable brain metastases. Can you explain what you meant by that? What does it mean to have a stable brain metastases?
Right. So what I was thinking about is really clinical trial eligibility criteria. That is, when you are considering a clinical trial, typically there is language about your brain metastasis status, whether your brain metastasis is worsening at the time you enter the trial, which is typically called active brain metastasis, or your brain metastasis is stable, which is usually meaning that you've had radiation treatment, or you've had surgery, or you've had some sort of treatment that has stabilized the brain tumor. And so when you go onto the trial treatment does not necessarily have to shrink your tumor or control it in order to control, for example, disease outside of your brain. And so this is a term that we often use mostly in the context of clinical trials as we think about which clinical trials might be appropriate for patients. Almost all breast cancer trials now include patients with stable brain metastasis. So that was not the case 10 years ago, but now it's really the exception if a trial excludes patients with stable brain metastasis. But most trials still exclude patients with active brain metastasis. And so if you're looking for a trial treatment to treat your brain metastasis, then you need to look for trials that are looking for patients with active brain metastasis.
Thank you so much. Unfortunately, that is all the time that we have for questions for today. I do encourage our panelists, if you have time to stay on and respond to any of the questions that we haven't had a chance to get to yet, feel free to type and submit your answers in the Q&A box. But I just want to once again thank our wonderful panelists for taking their time out to share their insight and expertise with us. I also want to thank our partners at Living Beyond Breast Cancer for their partnership and support in putting together this webinar. And a special thank you to each one of you, our attendees, for joining us. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282. We also encourage you to learn more about our partner, Living Beyond Breast Cancer, by visiting their website at lbbc.org or calling the Breast Cancer Helpline at 1-888-753-5222. Thank you again for joining us.